Dr. Snell, members of the committee, and the audience, thank you for listening as I, Taylor Anderson, DNP student at Maryville University, present my Doctor of Nursing Practice project entitled Pediatric Mental Health Quality Improvement. I want to take a minute to recognize some important members of my committee, including Dr. Maria Snell and Dr. Rita Wunderlich, as well as my former chair, Dr. Kathy Wright. I would also like to thank my family and mentors who have supported me throughout this project. After collaborating with the lead physician of a small rural pediatric primary care clinic in the Midwest of the United States, adolescent depression was the subject of topic that prompted this research project. Ultimately, there was no standard screening process in place, and the fear of missing depression in the adolescent population they serve ended in consequential outcomes, prompted the work of this project to improve practices and overall patient well-being. This posed the question, does the use of standardized screening with the depression tool in adolescents 12 to 18 years old improve the detection and the diagnosis rate of depression compared to not screening and only addressing concerns that may be brought forward? The American Academy of Pediatrics has recommended that all primary care providers should in fact be screening for depression at least annually. However, it continues to not be a common practice in primary care pediatric clinics across the country. An estimated 1 in 5 adolescents is affected by mental health problems, and ultimately many continue to go undiagnosed when reporting to healthcare providers. When mental illnesses are left untreated, such as depression, it can have negative outcome for those involved, including self-harm, attempted or successful suicide, and beyond. According to the Office of Adolescent Health 2018 and Barrett and colleagues 2016, geographical areas do not matter, as adolescents in urban and rural areas have the same incident rate of depression, and with the lack of screening to detect these illnesses, leads to increasing number of ER visits due to negative consequences of mental illness. It can be difficult for adolescents to come forward regarding their feelings, as it is for anyone, but this can lead them to decisions they feel are out of their control, leading to grief and loss if successful, and suicide if severe enough. Even if the adolescents are not attempting suicide, it does not mean they are not having negative consequences, including slipping grades, social isolation, drugs and alcohol, trying to cover up their feelings, and much more. Ultimately, the American Academy of Pediatrics has set forth these guidelines for primary care providers that should be screening for depression and be able to manage the diagnosis through treatment options when mental health providers have a wait list. Beck and colleagues 2016 provided evidence that the Patient's Health Questionnaire 9, or the PHQ-9, is an effective and efficient tool to screen for depression in adolescents. And the PHQ-9 in primary care can aid in the limitations of appointments that are time sensitive, but can also help in earlier diagnosis, earlier intervention, and improved outcomes. With this in mind, there's a rural Midwest pediatric primary care clinic that had no standard screening in place, and screening was only occurring when parent or patient brought concerns forward. As you can imagine, during these fast-paced visits, parents and patients do not always believe they have the time to discuss concerns, especially ones like depression or mental health that seem daunting and scary. We must think of how many adolescents have walked through the door of this clinic and a misdiagnosis of depression was the outcome. Ultimately, primary care providers seek to ensure prevention and early detection of problems. Therefore, just need to ensure updated processes and guidelines are also set forth to do just that, including depression screening. The research to improve screening in primary care has crucial implications for patient outcomes by not only getting them help earlier, but reducing injury, harm, and even death. The AAP has set forth these recommendations for a reason, to encourage depression screening in adolescents, presenting to primary care providers, and each primary care provider needs to be aware of the reasoning behind this guideline. Not only will the screening help reduce physical harm to patients, emotional harm to families, but also each community will have improved mental health of their adolescent population that will eventually join society as a productive adult. reduce mortality, and ultimately reduce healthcare costs through reducing the number of ER visits for untreated depression or attempted injury or suicide. Communities suffer great grief and loss when adolescents take their own lives, but also hurt when they hurt themselves, hurt others, or whatever the damage of undetected and untreated depression may lead them to. $211 articles were identified through the literature search using Maryville Library and the University of Nebraska Library. Of those 211, 14 were selected for the use in this project, all of which were between the dates of 2016 and 2020, and I utilized several quality improvement reports, subject reviews, and guideline reports for practice that offer recommendations from the AAP through a review committee. Utilizing Erik Erikson's 8 stages of psychosocial development theory as a theoretical framework, the identity versus role confusion was the stage that helped guide this quality improvement project. This stage, defined by adolescent years as children transition from childhood to adulthood seeking who they are. We recognize how detrimental depression can be to this point of time if left untreated or undetected, as they may not be able to truly seek their identity and be able to see how their environment, their culture, and experiences shape who they are becoming if it is hindered by untreated depression or mental illness. It is essential to identify these problems so these adolescents can thrive and truly find themselves during this stage. And as Erikson wrote in his book, it is essential for individuals to complete each stage to transition to the next. Ultimately, mental illness such as depression can keep these adolescents from being successful in Erikson's identity stage and can lead to role confusion and ultimately difficulty reaching the next stage of intimacy versus isolation as a young adult. So the project was a quality improvement project that included implementing a depression screening tool, particularly the PHQ-9, by a pediatric clinic, and then performing a retrospective exploratory chart review to compare the pre-implementation and post-implementation ratios of the diagnostic rates of depression. Taking place in this rural Midwest United States pediatric primary care clinic, the sample sizes for pre-implementation was 120 patients, and the post-implementation was 43, with the average age of 14.8 in the pre-implementation group and 13.8 in the post-implementation groups, respectively. We also had almost half males and half females in each of the sample groups. This particular clinic has 2 full-time pediatricians, 1 full-time physician assistant, and 1 part-time pediatric nurse practitioner, along with 5 licensed practical nurses, 2 triage nurses, and several clerk staff. Education was provided to the nursing staff on the use of the PHQ-9, as well as the data on why depression screening is recommended by the AAP a month prior to them implementing the PHQ-9 into practice. Pre-implementation data was collected for 4 months prior to implementation, and post-implementation data was collected for 4 months after implementation. There was no patient recruitment. As the researcher, I did not have anything to do with the screening for steps taken upon identification of a positive result. They implemented the PHQ-9 successfully as of January 1st, 2021. The data collection tool I created for this project was simple and easy to use, only collecting the data necessary information to protect the subjects that could be replicated by another researcher. This data collection sheet used for our data extraction and coding helped eliminate any patient identifiers, protecting the subjects. I was not a part of the implementation and only collected the data through a retrospective chart review, while the clinic staff implemented the standardized screening with the PHQ-9. The data collection sheet allowed myself to separate the data on two separate sheets, one pre-implementation and one post-implementation, and included assigning each chart a number, collecting only the age, gender, ensuring a consent to treat was obtained by the clinic, and lastly, if a depression diagnosis was given. It was also essential to ensure the PHQ-9 was administered to the post-implementation group to ensure accurate findings, and those patients seen during this period that did not receive the PHQ-9 were not utilized in the data collection. After discussion with Dr. Mark Pauls, the statistician of Maryville, the statistical test chosen was a z-test to compare the difference among two proportions. This allowed us to run the proportion of adolescents seen during the pre-implementation timeframe that were diagnosed with depression and compare it to the proportion of the post-implementation period that were diagnosed with depression. Descriptive analysis was conducted to identify the differences among proportions, as well as make recommendation if standardized screening in adolescents was beneficial. Ultimately, there was a significant difference of 0.58 or 58% among the two proportions, with the pre-implementation or group 2 being 0.15 or 15% compared to that of the post-implementation or group 1 being 0.74 or 74%. Therefore, I was able to conclude that there was an increase somewhere between 44 and 73.17% after implementing the PHQ-9 in the diagnosis rate of depression. This is a large increase in the number of positive diagnoses of depression, and think if the pre-implementation group had been screening, we could estimate the number of diagnoses of depression to double or more, and therefore have to consider how many were missed during this period before the staff started implementing the PHQ-9 into practice. Despite the differences among our group sizes, with the level of significance of 0.05, we feel we have a strong results to again reiterate the importance of at least annual depression screening in adolescents when they present to their primary care providers for whatever the reason, whether being a sick visit or sports physical. With the green being the pre-implementation and the blue being the post-implementation, we can see a majority of the pre-implementation group was negative for depression, while the majority of the post-implementation group was positive for depression, therefore signifying the need to screen. This graph depicts a strong recommendation for standardized screening to be implemented as part of the routine process in adolescent patients to screen for depression. Although the sample sizes varied, there is still strong evidence to prove screening is important and can improve detection rates in not only a rural pediatric primary care clinic, but all primary care clinics nationwide offering services to adolescent patients. We have to consider this a fairly small rural pediatric clinic, and what would our results look like in an urban pediatric clinic if the same study was performed there? How much stronger would our statistics be? The limitations I faced included variation in sample sizes, the SARS-CoV-2 pandemic, and missed opportunities for screening during the post-implementation period. First is the variation in sample size of the pre and post-implementation groups, as there were a lot more patients meeting the inclusion criteria during the pre-implementation timeframe compared to those of the post-implementation period. Next was the COVID-19 pandemic that has altered the number of patients typically seen in this rural Midwest pediatric clinic, as many patients and their parents are still avoiding healthcare unless absolutely necessary, and then the changes in mandatory health screening set by the schools that were bypassed during the pandemic and still in effect today. A lot of these included sports physicals no longer needed every year, so less adolescents were coming in for those physicals. Lastly was the number of patients that had to be excluded in the post-implementation sample due to the lack of screening during this timeframe by a few providers, possibly due to lack of provider buy-in, but could also be attributed to the staff's decision to use the paper copies of the PHQ-9 in place of electronic administration. Electronic administration could have been set to prompt screening and hopefully lead to fewer patients missed and having to be excluded. However, these limitations did not impact the outcomes of the study, and we were still able to see significant results in recommendations needed. Depression is something that can lead to life-taking measures, and it affects pediatric patients at a high rate globally and continues to rise. We've seen a great rise during this COVID pandemic of even more adolescents struggling with depression. Primary care providers are on the front line, and it is essential to combat this rising rate and improve outcomes for these adolescents. My project verified the need for routine screening that found to improve the rate of detection, therefore improving outcomes by earlier treatment and interventions. As I begin my career as a primary care pediatric nurse practitioner, I am dedicated to ensuring my adolescent patients are screened for depression and ensure that the clinic in which I work is educated to ensure all adolescents presented to our practice are screened at least annually. Mental health has impacted my life so much as I have watched family and friends suffer with things such as depression and witnessed firsthand the grief and loss of a community after losing several adolescent patients, including a classmate, to suicide due to undetected and untreated depression. Adams and colleagues 2017 confirmed the effectiveness and efficiency of the PHQ-9 in adolescents, and therefore it's a great tool to recommend for the implementation as a standard routine screening instrument within pediatric primary care for all patients over the age of 12. Although there are many different screening tools, the PHQ-9 is one that I have taken and given to my college students and would highly recommend to any provider caring for patients over the age of 12, whether MD, NP, PA, whatever the situation, screening just needs to occur. From past experiences, I have found that adolescent patients do not broadcast their emotions unless you have built a great rapport, and even then, you still have to dig to get them to talk openly, hence the need for screening to ensure their overall health is considered. Primary care providers are in a perfect location to screen at least annually to ensure prompt diagnosis and the earliest intervention possible. As I began practice as a pediatric nurse practitioner in primary care, I understand the concern of appointment time restraints, but the PHQ-9 is fast, effective, and no such restraints should be used. Time cannot be a reason we are not performing the needed education and prevention screenings that will help our patients' overall well-being. Lastly is the need for collaboration in helping improve interventions provided and improve outcomes, and should include finding resources such as counseling and psychologists or psychiatrists, and building relationships to foster collaboration that providers can refer patients to, as implementing routine screening is going to increase that number of patients needing referred. Again, primary care providers and pediatrics are at the front line of combating the rise, and therefore screening adolescents for depression should move to the top of the radar. COVID-19 has only proven to be harder on this population, and therefore now is the time to change our routine practices and include depression screening. This project has proved to me as I begin my journey as a pediatric NP in primary care the necessity of screening adolescents for not only depression, but other mental health concerns, at least annually, despite the reason for their visit, to ensure earlier detection, earlier interventions, and better outcomes. These improved outcomes not only affect those adolescents and their families, but our overall communities, as there will be a decrease in ER visits from self-harm or attempted suicide, as well as emotional distress of communities when suicide is successful. This I have witnessed firsthand. I want to ensure my nursing staff and colleagues understand the importance of screening, as well as how to address concerns when they are identified. There are several insights found from further research, including further proof of success screening with the PHQ-9 in adolescents, the best educational efforts to spread the knowledge and proficiency of mental health detection and management if unable to see specialists for a period of time, and lastly is effectiveness of other screening tools that could help detect depression in adolescents, to offer a variety of screening tools offering the same effectiveness and efficiency as the PHQ-9. We know the shortage of mental health care providers is significant within our country, and therefore I urge primary care providers to do their due diligence and seek information and knowledge regarding even just the basic medications that can be used to treat mild depression in adolescents, as the time can be weeks to months. It is not safe to let these patients wait this long with no help, whether medication or non-pharmacological methods such as counseling. Also, we need to ensure follow-up to keep a close eye on these patients so they do not slip through the cracks, leading to those negative outcomes we have discussed. Once again, screening for depression in the adolescent population is proven to be needed and should be standard process and mandatory among primary care providers. The PHQ-9 is a tool of choice for myself, as it is proven effective and is simple and efficient in detecting depression in a fast-paced, time-crunched practice. This project utilized literature to back the findings of necessity of screening and making it a standardized practice process in primary care offices, despite geographical locations. One thing I would do differently is conduct data collection at the same time of year. For instance, in the summer when adolescents present for sports physicals, and collect pre-implementation one summer and post-implementation the following to get similar sample sizes and hopefully larger sample sizes. I would also want to go further and adjust the response to positive screenings, as I do think how a provider responds to a positive screening is essential to look at to improve outcomes, as some providers may just go through the process of screening, but then not address it at all or even completely. As I begin my career, mental health is something I want to stress when conducting adolescent visits, including education for patient and parents of warning signs of mental illness and helping them recognize it is not a horrible thing as the stigmas may make it seem, but something that does happen and can be helped. They do not have to feel this way all the time. This DMP program has taught me so much in terms of researching, and I feel it has better prepared me for practicing as an advanced practice provider. I would highly recommend Maryville University's DMP program, and I've thoroughly enjoyed conducting this project despite the obstacles and the challenges that I faced. Thank you all for listening, and I will answer any questions you may have if you would kindly just post them.